Thank you.
We will have more time for discussions, but because we stay somehow now in the field, and I'd like now to hand over to Olav Pedersen, who has many years of knowledge actually in, among other things, in home monitoring, in not normal pregnancies, but in highest risk pregnancies. And we're going to hear from him some thoughts about COVID-19 being actually an opportunity here. So Olav, the stage is yours.
Well, thank you so much to everybody and to Martin for the invitation for this. And Sonia, just to add on a small comment about resistance against innovation and also implementation of new techniques. I think being beyond 60 years, I really do think, also from my experience, it's a little more about mindset than it is about age, because I've experienced, I mean, a lot of resistance actually from also junior doctors who is much more, at least in obstetrics, focused on doing what they think is safe, which is then the old thing. But now I will tell you about our experience about mobile monitoring of pregnant women in Denmark, especially in the context of the COVID-19. Can you all see the screen? Mm-hmm. So why do mobile monitoring of women with pregnancy complications? So that's the question. So one of the answers or background is this graph here. It's the graph of pregnant women with new cases per week for the last half of last year of 2021. And I mean, and this graph here could be replicated in all population of all countries, but also among the pregnant women. So at least this would put a burden on our system. But another graph, which is maybe a little more surprising to some of you, is this graph showing the number of hospital beds for 1,000 citizens. And Denmark is the green one down here, the second lowest among these countries here, with 2.5 beds for 1,000 citizens. And in Germany, at the top of the list, it's more than 3 times the number of beds, which could then be a logistic and practical problem if you suddenly experience a change in patients. And then so for a long time, in the beginning of the COVID pandemic, everybody thought that for young people, also for young pregnant women, COVID was not that dangerous or dangerous at all for the mother or the baby. They were normally young people without concurrent medical conditions. But then last summer, this is from May, stories about women losing their child maybe to COVID came around, which of course did a lot of turbulence among the pregnant women, but also the clinicians. And we sat down in our scientific society in Denmark, established a working group where we started to look at the numbers, comparing number of complicated, both maternal but also from the fetal side, cases in June to November in 2020, and then compared them to the same period in 2021. And apparently something changed, which is then in the same period where the subtype of SARS-CoV-2 changed to the Delta variant, and suddenly we started to experience fetal or neonatal deaths, which was much higher in the latest period. The Americans could collect the data of 1.2 million pregnant women and did the same, comparing pre-Delta to the Delta period. And in the Delta period, the rate of fetal death was close to 3%. So this is a huge risk, and it's something really new that we haven't seen for many years. So that really changed our approach to the problem we had. So what happens is that the baby don't get infected because the placenta is a very good filter against the virus, also the SARS-CoV-2, but the placenta itself can get very severely affected, and in the severe cases can get this placentitis. And even though that I think that many of you doesn't normally look on fresh placentas, I mean, these pictures, it doesn't look nice. So this is a picture of a placenta with this placentitis. And recent studies has shown that the changes in the placenta is very similar to the lung affection, which is caused by the Cytokin-storm in the patients with very severe lung affection by COVID. And maybe it's not that strange, but because the placenta is the fetal lung in some ways. So as Antonia has shown us, our way of monitoring fetal condition, the fetal well-being for 50 years has been CDG, synchronous registration of fetal heart rate, uterine activity, and also fetal movement. So it is a way of doing a neurological intrauterine assessment of the baby. And this is used to be done in hospital because you need some hardware, which is normally quite big and expensive, and you also need a bed. So for many years, and in the majority of places, it's done in hospital. And recently there's been these papers showing that in case of placentitis, this severely affected placenta, you will get CDG changes that we can recognize as being abnormal or severely abnormal, as in these cases here, just published recently in the BJK from a Swedish group. So it seems as CDG monitoring is helpful in the identification of the fetuses at highest risk. So our scientific society raised a COVID alarm here in early December, saying that the women had to be aware of changes, even if they themselves had a mild COVID. Then if they experience change in fetal movements or anything else, then they should contact the doctor, which they did. And there came in the idea of using the mobile concept for this field surveillance. So this is a real patient doing home monitoring with a Monica device, and this trace is done by herself. So you have the registration of the fetal heart rate, the maternal heart rate, the uterine activity. So this is possible by home monitoring producing basically exactly the same tracing, and sometimes actually in a better quality, and can be done everywhere, and also by the woman herself. So in Aarhus, we have developed a mobile platform just using a standard tablet where we can transfer the data from the CDG, but also from other measurement and devices into the hospital system and into our hospital CDG registration system also, so that we assess the CDGs in the same system, whether they are done at home or at the hospital. And we have just published our result from the first 400 patients of light to moderate to severe pregnancy complications. And the conclusion was that mobile or remote monitoring was feasible, it was safe, and with outcomes comparable to, or maybe even better in some of the subgroups than reported with inpatient care. So we think we were and still are ready to run to increase the number of these women that we have on mobile or remote monitoring. What happened then? Well, first, the rate of vaccinated women increased significantly over the last part of last year, going from 3% to more than 3 out of 4 before New Year's Eve. And definitely the stories about COVID is not just a small virus. It can be threatening to a pregnancy, and which has been very helpful in the communication to the women. And we are at the moment collecting data from early 2022. So I think this has continued to grow. So this graph here, again showing the last half of last year, is the proportion of women with COVID-19. The blue graph here is the unvaccinated women. The red one here is the women vaccinated 2 times, and the green one here is the women vaccinated 3 times. And it's the proportion of all pregnant women in Denmark. And these are numbers from the National Board of Health. Again, it is the proportion of new cases each week. And this is the same graph, but instead of proportion, it's the actual numbers of pregnancies. And here, because the proportion of vaccinated women is so high, then also the number here is higher. And we know that they have a less severe course because the majority of all the severe cases with fetal demise were among the unvaccinated women, which was a very important message to the pregnant women. Another thing which also changed the whole scenario here in Denmark, and I think across the globe, is the change of the subtype, the variants of concern. This is data freely publicly in Denmark. It's where we sequence many of those cases. So this is the last 3 months, and this is the proportion of the different variants. The blue one here is the Delta, and this is the Omicron. And here from mid-January, I mean, close to 100% of all cases are now Omicron, with a much less severe course as far as we know. But then a few days ago, the Deltacron came around, and we know, I mean, this is going to change, I mean, likely for the rest of our life. And we don't know anything about whether the combination of spikes with genetic footprint like Omicron and Delta, what it would do to the patients, to the placenta. We still have to see that. But we're still ready to run. Now we can, as Antonia showed, by a range of different devices which can be used for mobile or remote monitoring. And I think we have to do this because, I mean, we will face ever increasing challenge of our hospital system and decreasing number of staff. So, I mean, irrespective of which type is around, we just have to change our mindset. And not only because of the resource thing, because there are so many other good reasons why we should do this. It's empowerment of the women. This is Mette, one of our first patients. I mean, it was amazing what she could tell, what this did to her and her well-being. It's a regain of autonomy. It's a regain of the controller of your life, and also mobility, because hospitals are not very good places, I mean, to move around or to stay. It's unhealthy to stay at the hospitals. And this last slide is the message from our very first patient, who was Tina. She was facing 14 weeks of hospitalization. And then I came back from a conference with my first medical system. And we sent her home with that. And she was, as you can see, very happy about. She saved about 7 weeks of hospitalization. And she was the first one convincing me, we have to do this in a much, much higher scale that we currently do, because of the resistance. And Tony, you're so right. It's out there. Thank you so much. Oh.
Olaf, thank you very much. I mean, I was impressed last year, and I'm even more impressed this year. And although, well, as we said, well, COVID is a horrible pandemic, and other things have changed, but this is definitely a sign for future development and collaboration. And the risk you've taken, I think, also personally, to get these 400 pregnancies managed and published is really remarkable. And I think the field really has to thank you for this effort. I mean, for us, this was very important, as you know and others know. Well, we as manufacturers of CTG monitoring devices do have to write clinical evaluation reports, and we also justify the absolute need now to finally start to broadly use telemonitoring by this paper from you. So congratulations again for having done this. The other part is I just like to mention, well, maybe not for you, but maybe for others, you had a couple of slides where you said, well, these data are from the National Board of Health. Yeah, so that sounds like a simple thing, but it illustrates what I always call the digital stone age of Germany as compared to the UK and in particular Denmark. No way we could produce anything like this for Germany. Yeah? And that's a lesson, I mean, for all the sectors here, maybe with the exception of the work of the Max Planck Institute with the work on aerosols, that if you have good data and available data, well, then you don't have to have fancy and complicated algorithms. Then you just, I mean, do pretty obvious things. And if you don't have this because you have not organized this, because what you sometimes call the data warlords that exist also in Germany, that sit on that data and are afraid to share it and so on, that is really very damaging. And I would hope that one thing emerging from this conference is at least European, hopefully Ukrainian, Russian collaboration to get things right. Yeah. Okay, so that was my comment. So Antonia, you have your hand up.
Thank you very much for a nice presentation. Just briefly, one comment I would make is that I stay in touch, right, with the mothers and PPI, as we call it, public and patient involvement in this kind of research.
Yeah.
I feel that the climate in the UK, from my own personal perception, is getting better and better with time towards home monitoring. British pregnant women want to be empowered, autonomous, have control, put the monitor themselves, hear their own baby's beat. I mean, come on, it's so much better than having to go to a hospital. Once you have one child, going to hospital, it's a nightmare. There's no parking as well. Who's going to take care of your other? There's so many benefits to women. So I feel that it's becoming, I think the climate is ripe in the UK, I think, for that, almost nearly ripe. The question I would have is two questions. One is a bit more specific. I saw the Monica monitor on your slides. So on a research level, how does it affect you, and does it affect you that Monica got sold to GE Healthcare? What kind of devices do you think can work? Because this is still a bottleneck from my point of view here, but I might be missing stuff. So a little bit more around technology and Monica versus Nemo or others and the expensive wearables and so on. And finally, a bigger question maybe is, do you believe that, because that opens the door and opportunity to start collecting data at scale, more, longer, every day if you wish, and so on, in a way that we were never able to do before, right? Without home monitoring, you would have one CTG if you do. So any potential around that, because we saw research with Monica devices when they were available for research, like Peter Stone in Oakland, but many others as well, when women were able to wear the device all night, and we started seeing data about these fetuses in a way we've never had before. So how is that looking at what is the chance of us starting to collect as a society, learning more?
Well, I mean, the story about the Monica being bought by GE was an absolute catastrophe, because in Denmark at that point we had 3 national meetings with representatives from all departments. We were all going, I mean, yes, we're going to do this, and we came on the budget. This should be a national implementation, which should be finished in 2020. So I mean, everybody was so happy. This is changed things. And then the night before one of the national meetings, Danish called me saying, well, he had some bad news, and I still remember where I was sitting because I didn't believe it. And we have been, I mean, in a pit stop for 3 years, but we have done a national tender where we have evaluated thoroughly 3 different devices, and Nemo Healthcare won the national tender. So I think the good thing about this is that the technology and the companies, something has matured over the last years, which is, I mean, it's 4.5 years now. So and Nemo Healthcare just got EC approval, but there are other companies around, Nuvo, but several others. So I think we will rapidly see many devices, and now, I mean, within the last 2 weeks, a lot of departments in Denmark have started ordering devices again, and we have restarted the whole process about arranging national meetings, because of many reasons we need to get this rolling, and then we have to establish national research collaboration to do exactly what you said, because when we have this in big numbers, then we have the environment and the patients and the devices where we can start find out what's possible, also for what you said regarding how can we somehow risk stratify if we do monitoring a longer time of the conditions. So I think we are looking into another future, and I hope that also machine learning at some point can help with the risk stratification in these cases. Is that what you asked me about?
Yes, I need to be quiet now so we don't hijack the meeting. Let's talk again. I'm looking forward to the discussion.
Yeah,
very interesting. Yeah, and answered my
Okay, so then thanks again for Olav for the presentation and the discussion. And then now let's move to the